Evening, Nitin Shah, sir.
Good evening, Abba.
Good evening, Sanjay, sir.
Good evening, Abba. Welcome.
Good evening, everyone. I welcome all the delegate faculty speakers for this MahaIP's program on behalf of MahaIP. I am being a Dr. Sachin Patil, EB MahaIP 2025. So today is the 10th episode of Vaccine Samvad. This is the one of the biggest academic bonanza from the MahaIP for all the MahaIP members under the able guidance of Dr. Nitin Shah sir. So now I request Dr. Sanjay Pakmode sir for the welcome address. Over to you, Sanjay sir.
Thank you, Sachin. Namaskar. Welcome to the MahaIP platform. And welcome to this particular blockbuster program of the MahaIP, that is the Vaccine Samvad. Generally, it is scheduled on the first Friday of every month, but actually the sir moderator, Sir Dr. Nitin Shah sir, were out of station, and as well as it was not feasible for the panelist also. So it was postponed from first to the last Friday of this particular month. So this is the second last program of this year, and it is very much attended by the people from all over the India. And as Sachin has told, this is the 10th program of this year. So in this Vaccine Samvad, Dr. Nitin Shah sir is a moderator. We know sir is a man of international repute, and sir is inviting the panelists from all over the India, and so many panelists came for this particular program. Now for today's program, we got Dr. Sunil Agrawala sir from Cuttack, Odisha. Sir has just now told he's Jim from the east, and Dr. Balasubramaniam sir from Chennai, from the south. So I welcome both of you, sir, to this particular MahaIP platform and the program that is Vaccine Samvad. Now, vaccination in the special situations. In the initial episodes, we have covered one vaccines, and then we covered the vaccination in the special conditions. And today we are having the topic of the vaccination in the special situations. Now, in the practice, we see routine immunization is known by each and everyone, as told by IAP schedule, what we are following. But sometimes in the OPD, the situation comes, the patient is coming with certain conditions where we really wanted to know, we must be updated with the particular what vaccination should be given or should not be given, because ultimately vaccination is giving to the boon for the patient, but at the same time we must analyze what can be the adverse effects of particular vaccines in that situation only. So in practice, we come across with so many situations like vaccination in the immunocompromised host, vaccination in the patient who is on the corticosteroid treatment, then the vaccination in the patient whose spleen has been removed, splenectomy has been done, then vaccination in a patient means particular means in because parents are asking us, can be in the minor illness also they can ask us with where the vaccination should be given, or if the patient is suffering from the major illness and the vaccination is due, there is a query whether it should be given or not. Then for the mother also it is a problem whether in the pregnancy or lactation it should be given or not. Then travelers, then the vaccine, sometimes the situation comes when the patient have lost the records and they say we don't know what vaccinations has been given. And then the catch of vaccination, my child is at all not it at all not immunized, then what can be done for that particular patient? So today's panelists are going to deliver tell us and update us how to go for the vaccination in these special situations. So it's going to be a very important learning from all the experts. And so I means hand over the mic to the Sachin with the further proceedings.
Thank you, sir, for your blessings. Now I request our treasurer, Dr. Ravindra Sonone, sir, for the welcome address.
Yes, thank you, Dr. Sachin Patil. Uh, Good evening, respected seniors, dear colleagues, and delegates joining us from all across the Maharashtra and India. I'm Dr. Ravindra Sonone, Treasurer MahaIP 2025. It's my absolute privilege to welcome you all to very special milestone tonight, the 10th episode of our flagship academic series, that is Vaccine Samvad. This academic journey envisioned by our dynamic president, Dr. Sanjay Pakmode, and the team MahaIP 2025. Special mention to Dr. Minaj Sheikh sir, scientific convener. Then our Dr. Sanjay Deshmukh sir, convener, and then VP Dr. Agrawal. So, and team MahaIP 2025 has been dedicated to keeping us updated on evolving field of vaccinology. Today's topic is vaccination in special situation is one of the most clinically relevant subject we face. As a pediatrician, we often encounter dilemma when treating children who are immunocompromised, premature, or facing unique health challenges. Standard schedule don't always apply, and precise knowledge here is what separates good care from excellent care. To guide us through these complex topics, we don't just have expert, we have the stalwarts of the field. First, I welcome our mentor and moderator, director and script writer, named synonymous with vaccine globally, Dr. Nitin Shah sir. He is my guru from Mumbai. I extend warm welcome to our distinguished panelists, Dr. S. Balsubramanian sir from Chennai, Dr. Sunil Kumar Agrawala sir from Cuttack, and our friend Dr. Rishi Lodaya from Nagpur. And I also welcome our MMC observer for the evening, Dr. Shirish Deshpande. Here I am seeing Jitendra Gawani also, and all my friends and seniors. So I will also like to remind all delegates that this session carries one MMC credit point. So without taking any more time between you and experts, I wish everyone fantastic learning lesson. Let us unlearn and relearn together. Over to you, Dr. Nitin Shah sir or Sachin Patil.
Thank you, sir. Now I request our convener, Dr. Sanjay Deshmukh, sir. Are you there, sir?
Yes.
Yeah, he's there.
Good evening. Welcome to MahaIP platform. Dr. Pakmane sir rightly said last 1 year, this Vaccine Samvad was started in January and it is conducted in the first week of every month. And it was not possible if our dear Dr. Nitin Shah sir had not accepted this task. And I hope we will have the opportunity next month to thank him. But now we are coming to the end of this year. On behalf of MahaIP, we are extremely thankful to Nitin Shah sir. He has make our MahaIP platform happening place to discuss all the vaccinations. I hope next month, January is coming, December is there. So we'll make December end another session, and that session will be have official thanks given to our mentor, Dr. Nitin Shah sir. And it is possible due to the fantastic scientific committee, Dr. Minaj sir, Dr. Manish Tiwari, and we get galaxy of speakers. Today we have Dr. Bala Subramanian sir from Chennai, my dear friend Dr. Sunil Agrawal sir, we are AB together, and my dear friend Dr. Rishi Lodaya from Nagpur. So it will be great learning things, and I hope And I wish this Vaccine Samvad will continue years in MahaHappy platform. And thanks and best wishes to Sachin for conducting to this session.
Thank you, sir. Minas, sir, please.
I think good evening to all, and we start the proceeding right away. Over to Sachin for the next. Thank you. Welcome to one and all.
Thank you, sir. Now there is no need to uh, introduce our expert because everyone had our moderator. Everyone has praised respected Dr. Nitin Shah, sir, past president of Central IIP. Sir is always the famous name for the vaccine all over world, not India. Sir is a section head of pediatrics, PD Hinduja Hospital, and sir is a pediatric hemato-oncologist at Bichewadia Hospital also. As mentioned, President Central IP 2006, and sir is author and for multiple journals and publications. So, welcome Nitin Shah sir from
Thank
behalf
you.
of MahaIP.
Thank you. Thank
Our
you.
next panelist is respected Dr. S. Balasubramaniam sir. Sir is a visiting consultant at Kanchi Kamakoti Child Trust Hospital, Chennai. Sir is head of academics, Institute of Advanced Pediatrics, Rela Women's and Children's Hospital. Sir was a chairperson of IIP Infectious Disease Chapter 2022, and sir was convener at IIP ACVIP in 2018 and 19. Sir is famous in ID chapter. Every pediatrician knows from all over the globe. Our next panelist is Sir. Welcome, Balasubramaniam sir, from behalf of MahaIP. The next speaker is panelist is this Dr. Sunil Kumar Agrawala sir. Sir is Professor Pediatrics from Cuttack, and sir was CIPEP member in 2017-2024, ACVIP member in 2021 also. Multiple publications are there from sir side. So welcome Sunil Kumar Agrawala sir from behalf of MahaIP. And next panelist is Dr. Rishi Loda sir from our Vidarbha, Nagpur. Sir is a director of New Health City Hospital, Nagpur, and attached to Matrusha Sangh Hospital also. His own clinic. Sir was involved in many modules of Central IP. So now I request Dr. Nitin Shah sir for the further proceedings. Thank you.
Thank you, Dr. Sachin. Thank you, Dr. Pakmode, all the office bearers, all the conveners and the scientific conveners of this program. This is the penultimate session, and I'm sure you will like it because it's not on a particular specific vaccine. It's on a particular special situation, which, as everyone has said before, as to we get confused as to which to give and which not to give. And we promise that next month, December, again we will do at the end of the almost the last Friday, because that will be like a parting gift from me to everyone, a parting gift from Dr. Pakmode and the office bearers of Maharashtra State to all the members, and I'm sure we all will be present in large number for the last session for the year 2025. So with that, I will start with today's program, and I thought we should discuss this special situation because that's where a lot of confusion can happen. So I will start with Dr. Bala. I did a webinar at 3 o'clock today on preterm immunization and why it gets delayed. So my question is, what are the recommendations for preterm? I mean, you give it at the chronological age or at the corrected age, and why? You can unmute yourself, sir. Unmute yourself, sir. Dr. Bala, unmute. Dr. Bala is not able to unmute.
Okay,
Yeah,
okay.
yeah,
Thank
okay.
you.
Yeah.
Thank you, Nitin, and thank you, Maha EAP, for asking me to take part in the session chaired by and conducted by none other than my good friend, Dr. Nitin. Basically, when it comes to immunization of preterm, there are many doubts raised by the parents, raised by the obstetricians, and also raised sometimes by the neonatologists who take care of newborns. The fundamental principle is that the right age for preterm immunization is not the gestational age, is not the weight. I think those two things don't count at all. Every preterm can be immunized with all the vaccines that are there in our schedule or any schedule based on the chronological age and not based on birth weight or period of gestation. There is enough data that the immune response which occurs following routine vaccination as per chronological age is as good as those in term infants. The only condition is that there are some precautions which we need to take care. For example, we can't be worrying about vaccine in a very critically ill baby who's undergoing total parental nutrition along with ventilation, high frequency ventilation, and inotropes and antibiotics. We are not going to worry about immunization. So the infant should be stable, and you should start vaccinating according to the chronological age. Of course, that's my brief answer, Dr. Nitin. If you want me to
Yes.
explain, go ahead.
No, so my next question is that why is it even more important for preterm to be immunized as early as per the chronology and not wait?
Excellent question. Preterm basically is more at high risk for infectious disease and
Correct.
vaccine preventable diseases.
Right.
Not only at high risk, also at high risk of developing complications and serious disease, and also high risk of mortality.
Yes.
So it's a priority to vaccinate. In fact, for a preterm infant, we should go beyond the universal immunization schedule and give the vaccines, which we used to call them as optional vaccines. They are not called optional vaccines. They are other vaccines recommended by ACVIP, and even the newer vaccines like your RSV, etc. So we should
So
go
why
beyond the routine immunization.
why are they at more risk than a full-term baby? I mean, which arms of immunity are weak in the children?
Please repeat it.
So why are these preterm even more vulnerable than full-term?
Yeah.
Which arms of immunity are at risk or are not well developed?
Basically, preterms may not have adequate levels of immunoglobulin transfer
Correct.
third trimester from the mother. Some of the antibodies which may protect early newborn, for example, you give Tdap to a mother, the newborn is protected, young infant is protected. That might not happen if the baby is preterm because the maternal antibodies might not get transferred in the third trimester if the baby is born at 28, 30, 32 weeks.
Correct.
That's the main thing. And preterm, basically, any preterm which is low birth weight is going to undergo a lot of interventions. So any morbidity anywhere in any system in the preterm is going to make the baby vulnerable to the disease and also more exposed to the disease.
So very rightly said by Dr. Bala, the preterms have low neutrophil count, low monocyte count. They have a lower cytokine response. So their first innate immune response itself is not up to the mark. Then if they are born at around 32 weeks or before, the transplacental maternal antibody didn't have time to go. And that's the reason and why. And the third thing is their skin, which is the main organ for first resistance, is now being poked every now and then for some or other blood test. So all this makes this preterm vulnerable. In fact, the studies have shown that the incidence of pertussis is twofold higher. Hospitalization is 2 to 3-fold higher. Same way for the pneumococcal disease, the incidence and mortality are higher. So also for tetanus, if the preterm develops tetanus, is 2 times more chance of succumbing to the infection than a full-term baby, and so on and so forth. So many of these vaccine preventable diseases have 2 to 5-fold higher chance of morbidity and mortality. That's the reason why they should be immunized if they are stable enough, even while they are in NICU. Do not even wait for them to be discharged.
Yeah. In brief, preterm birth should be considered as an immunodeficiency state relatively.
Correct. But they can mount an immune response like any other baby. So they are immuno-naive, but not immunocompromised, that they cannot respond to vaccine, to which we'll come a little later. Now the next question, Dr. Bala, is you say, okay, you give these vaccines, a 1.1 kilo child, he just become stable and started feeding, came out of ventilation, say 1 week back, he's thriving. Is it safe? Will it lead to some complications? Because it can lead to fever and so many other things. Can it lead to any cardiorespiratory problem?
No, the preterm is not at more risk of developing the adverse effects of any vaccination than a term infant.
Correct.
Technically, the procedure of vaccination in a preterm is challenging.
Correct.
To give BCG in a preterm it requires a lot of skills, And many a time I have seen health workers ending up giving subcutaneous BCG vaccine rather than intradermal
Yeah,
vaccine.
even the muscle mass and the depth.
Muscle
Yeah,
mass is so small, you have to use a smaller needle.
smaller
You
needle
have
gauge.
to use a subcutaneous needle to give an intramuscular
Intramuscular.
injection.
Correct, correct,
And
correct.
third is, preterm, there is always fear of the you hitting the bone. So
Correct.
when you give any intramuscular vaccine to a preterm who's weighing 1.5, 1.6, and there is
Yes.
all the parents themselves, they'll be very much worried. The baby has just come out of ventilator and is going to be discharged from the nursery. They themselves have to be counseled that it is better to give vaccination and send. And the only vaccine about which you should worry about giving, the only vaccines which you should worry about giving are probably rotavirus vaccine and
So
hepatitis.
what is the problem with giving rotavirus? I mean, why do you say so?
If it is in a nursery, the virus can get transmitted to other infants
To the
who are.
stools of the child.
Yeah, so it's better not to give while the baby is still in the nursery. Even oral polio vaccine, for that matter, should not be given to somebody who's already there in the nursery.
Yes,
So the moment
especially because you may not know if there is a baby who's kid, who is
yes,
sick enough, and you have not still diagnosed, he can get into trouble. So if you
yes.
have given oral polio or rotavirus vaccine, maybe isolate that vaccinated child for 2 weeks, because that's the time of maximum shedding of these viruses in the stools.
Yes, yes. And BCG is technically very difficult if the baby is weighing 1 or 1.2. You can give at the time of discharge.
Correct.
Though, throughout the world, the policy of neonatal BCG vaccination is changing. For
Yes.
example, in the NHS UK, they have now introduced a new system of BCG vaccination. They do not give BCG vaccination immediately after birth. What they do is to screen for immunodeficiency, collect the
Yes.
screening reports by 28 days, and they postpone to 28 days. I am sure in India, like neonatal thyroid screening, in the next 10 or 20 years, we will have
Yes.
universal immunodeficiency PID screening in the newborn.
Yes. So
And
the least you can do is look at the CBC of the baby and look at the absolute
absolutely,
lymphocyte count. If you have
absolutely,
done, we would have done in a preterm baby, and if possible, do a screening by doing what known as T-track. Or there are molecules of the T cell which are circulating. If they are
yes.
absent, it tells you that the T cell is not working. This child is likely to be skid. So while that's a far-fetched thought, yes, it's possible to do.
Yeah, there is no emergency to give BCG vaccine.
Correct.
After all, in a baby who's born with 1.2 K, the baby is going to be in the nursery for about 2 to 4 weeks.
Correct.
Stabilize the infant and preferably give it at the time of discharge, by which time if there is any clue to immunodeficiency, you better not give BCG, because you'll end up killing the child due to BCG rather than SCID if it turns out to be SCID or some other form of immunodeficiency.
Perfect, because it can lead to BCGiosis.
Yes.
So in the afternoon webinar, I actually extensively reviewed the immunogenicity and safety of 6-in-1 AP and WP vaccine and the pneumococcal conjugate vaccine in preterm as small as less than 28 weeks, even up to less than 24 weeks. So there were three groups of children, 24 to 28, 28 to 31, 31 to 37, and compared with babies born above 37 weeks, so four groups. And the immunogenicity was just the same for all the antigens except the anti-HIV antibody more than 1 microgram, which is little less till you give the booster. But in any case, you are giving booster to every baby, so that also squares off. And for the conjugate vaccine, there is no difference at all. As far as safety is concerned, there has been some evidence of some apnea or some heart issues when you give vaccine. So it's good to observe these babies for at least half an hour after you immunize, especially the child who is a little unstable in the last 1 week and is below, say, 32 weeks or below 1.3, 1.4 kilo. Most of them are self-resolving and they do not need much resuscitation. So that's the reason why these vaccines are extremely safe, even in those preterm. So I think the bottom line is, for the preterm baby, there is nothing like correction of the age. Moment the baby is stable, even while in NICU, vaccinate the child, certainly vaccinate before discharging, and try to bring them back, because once a delay is always a delay, and we don't want that to happen and lead to a child or preterm baby who spend lakhs of rupees in NICU and comes back with a pneumococcal meningitis or a hip pneumonia or a pertussis or an influenza disease. So I think we have discussed enough
Two-
about the, yeah.
Nitin, just two
Yes, please.
points quickly.
Yes.
One is that if by any chance a neonate has received a blood transfusion,
Yes.
it's not a contraindication for giving any vaccine. That's a
Absolutely.
common myth. Some blood products have been given. Don't delay vaccination. Number one. Number two, you should proactively advise. Many a preterm may go to the government sector and get those vaccines. And you should tell them at 6 months it's better to give influenza vaccine to preterm infants.
Right.
And not only to the infant, but also to others in the family, other
Absolutely.
children in the family, because they are high risk for complications of influenza much more than other term infants. These are the
Yes.
2 points which you must remember. Of course,
Yes.
hepatitis B, it is better to avoid the birth weight is less than 2 kg. But
But
anyway,
in any case, we are giving 3 more in primary, so that would not matter.
so it should not matter at all. Should not matter at all.
So remember, the live vaccine like oral polio and rota being mucosal vaccine are not a contraindication. If someone has received IVIG or blood transfusion in the past, the only vaccine they do delay are the measles, MMR, varicella, which anyway you are not giving immediately. So as Dr. Bala said, do not delay vaccination just because someone received IVIG and or blood product. I think we will switch the gear now. I come to Dr. Sunil. Hello, Sunil. Welcome to
Yes, sir.
Maharashtra. Yes, sir.
sir.
So I
Yes,
will
sir.
discuss splenectomy with you. Why splenectomy is a special situation as far as vaccination is concerned? I mean, what happens?
Thank you very much.
Unmute yourself. Unmute. Sunil, unmute. Yeah.
Thank you very much, Nitin sir and Maha IAP for inviting me. And the question is related to splenectomy. Always spleen is the organ for phagocytosis.
Correct.
Once there is antigen, antibody, and complement that is being phagocytized in the macrophage system of the spleen. So
Correct.
that's why capsulated organism, they are being got into the spleen. If the
Correct.
spleen is not there, or spleen is not functioning, for an example, medical splenectomy like sickle cell anemia or
Correct.
other functional splenectomy, they are very
Yes.
prone for a capsulated sepsis. For an
Perfect.
example, pneumococcal sepsis, for an
Correct.
example, Hib, for an example, meningococcal, all those bugs are very, very common in splenectomized children. And I will say the salmonella is also having a capsulated pathogen.
Yes.
This is also not uncommon. I will say this is also has to be taken care in a splenectomized patient.
Correct. Plus, besides spleen is a major lymphoid organ of the body, and it also helps to produce antibodies. So whatever you want to do as far as vaccination, it's better to do it before splenectomy happens rather than after splenectomy. We will come to it a little later. So when to immunize a child who is planned splenectomy? In an emergency splenectomy, there is no plan. But in a planned splenectomy, when will you try to immunize the babies?
Sir, always the catch rule is that at least 2 weeks before splenectomy, all vaccinations should have been completed. For an example, if I am dealing with a 7-year child who is having hypersplenism and there is a decision that planned splenectomy, for that child, I must start one PCV vaccine followed by polysaccharide 8 weeks later. Then another dose of meningococcal vaccine, 2 doses at 8 weeks apart, 1 dose of salmonella typhoid, and another Hib. All those vaccines should be completed at least 2 weeks prior to splenectomy.
So now the question is, can you give 4 vaccines or 5 vaccines together on the same day in such a child? Like ITP patient is now waiting for splenectomy. We can't wait for too long. Can you give multiple vaccines on the same day?
So multiple vaccines can be given very safely because a lot antigen can be handled by our immune system in the body. It has been told that 10,000 antigens can be handled on a single day. But the thing is that how we are comfortably counseling the parents, they have to be agreed. That is a one concern. Otherwise, we can give a lot vaccines, maybe 3-4 vaccines in a day.
Yeah, and most of them are killed vaccines, so you can even stagger them a week or 2 weeks if the patient not ready to take it on the same day.
Yes,
there is no harm at all. Okay. Now, if there's an emergency splenectomy, traumatic, now when do you vaccinate?
Sir, if traumatic splenectomy, then splenectomy has to be done to save the life. Now, spleen has been already removed, and there was no time to give all those vaccines prior to splenectomy because it was an emergency. So what can be done? It has been seen that because it is the largest lymphoid organ and the immune paralysis kind of thing that do occur after emergency splenectomy, and they do revive at least amicably after 2 weeks. So it has been told you can start all those immunization, capsulated, meningococcal, pneumococcal, Hib, and also salmonella 2 weeks after the emergency splenectomy.
Correct. And I think the priority priority will be to first finish this capsulated organism vaccine. Even if some routine vaccine as per the age are pending, that can come a month later, but immediately you should give this capsule containing
Yes, sir. Yes, sir.
vaccine as far as possible.
Exactly.
All right. What about penicillin prophylaxis in the wake of now good conjugate pneumococcal vaccine being available? I mean, penicillin prophylaxis started many, many decades back when these vaccines were not there. Now with the PCV, do you still start it? If yes, how long you continue?
Sir, this question is a $1,000,000 question. When we go back to my MBBS days, that is a classical teaching that penicillin prophylaxis has to be given at least for 5 years, because
Correct.
it has been seen that pneumococcal infection and sepsis is more common earlier age, by up
Correct.
to the age of 5 years. So that
Correct.
is the recommendation. But
Correct.
now the PCV vaccine has come up, and now I will tell the PCV 14 pan India, almost all states and union territories, they are using this biological PCV 14. So once it is given 2+1 schedule in the national immunization schedule, so what happens? They are protected against pneumococcal infection. But
Correct.
however, we don't know whatever the race serotypes which are not there
Correct.
inside
Exactly.
the vaccine. So it has to be continued at
Correct.
least for 5 years as per the
Yeah.
recommendation.
So at least 5 years since the splenectomy or till the age of 18 years adolescence, because after
Right.
that the pneumococcal invasive diseases are uncommon. But we have seen in a medico a surgeon, I won't name, 40 years after splenectomy, he developed fulminant sepsis and died of it. So there is
Yes.
no age where it can happen. So that's why even when you stop the penicillin properly, you have to tell the parents that if there is fever, they have to be very, very careful and start the antibiotic first at home, amoxicillin, ampicillin, or even penicillin, and come to the doctor immediately, and then it can be taken over. All right. Now the question is, now your
So
PCV
one
20
line,
available. Yeah. Yeah. Sorry. Yes, sir.
just I wanted to tell that pentid, which is misused by almost all senior persons, or many a times the doctors, the pentid is nothing but a oral form of crystalline benzoyl penicillin. Its
Correct.
absorption is very erratic. So
Correct.
this should not be used, because the K-pen, the phenoxymethyl
So that's
ethyl
not
penicillin is
available.
not available in India.
Ah,
So that's why amoxicillin, as you rightly said,
correct.
amoxicillin 125 BD, or in 3 years above it is 250 BD can be given.
Correct. Okay, now the last question, and that's an important question. You have the 20-valent conjugate pneumococcal vaccine PCV20 or Prevnar 20. We'll take the brand name only so that people understand what we are talking about. Is available in our country, but not for use below 18 years. Is only used for adults, whereas internationally is available for use for even infant. In fact, it has replaced the PCV13 even for routine vaccination for infant. So suppose you have an 8-year-old child or a 10-year-old child who undergoing splenectomy for ITP. Can you still will have to give only Prevnar 13 followed by PPSV 20 after 8 weeks and after 5 years, or can you replace all this by just one dose of PCV 20 as an off-label use?
Sir, whatever the science tells that in India, the PCV 20, I mean PCV 20 valent vaccine is available, and it is recommended above 18 years. Now, question is that off-label use, is the answer is yes, but as per recommendation, either by DCGI, because we have to follow that. So that is, we should not, because right now we are using highest PCV 13, and that is recommended beyond 2 years, and we have to use that. And if the age is more than 6 years, then one dose, and 8 weeks later polysaccharide vaccine single dose, the same old story has to continue. But the
Suppose the
thing is that
patient said that I'm ready to give you written consent because my cousin in the USA said that they would give Prevnar 20. Why are you not giving? What
Sir,
would be your answer?
Sir, answer is that yes, I can give that. But again, it is a point-to-point interaction. If
Correct.
because the DCGI is not permitting, but for the
Correct.
sake of patient, I can go ahead, because the same brand is used in
Correct.
US, and they are using in 6 weeks onwards. So nothing will harm if I am giving that. I can give.
Correct. So just one question to Bala. I mean, this is nothing to special situation, Bala, but Prevnar 20, like someone has come from US, has taken one dose of Prevnar 20 there. Now he's due for one more dose before he goes back. And he says, no, you have to give Prevnar 20. What will you do?
I have given actually, Nitin.
Correct.
Only thing I have documented, I have
Yes.
given for a patient from Abu Dhabi, for a patient from USA, and even
Yes.
for this 8-year-old, I will put it in writing,
Writing.
document, sit down and with the parents and explain to them this has
Correct.
been in use for the United States for the last 3 years. And sometimes we can even tell them just because somebody has not given approval, it doesn't mean it is disapproved.
Exactly.
Correct.
Exactly.
Okay.
So I take a parallel, Dr. Sunil, that like say 15 years back or 10 years back, Prevnar 13 also not licensed above 5 years. So you're an 8-year-old child undergoing splenectomy. Would you not give any PCV at all?
Yes, sir. Yes, sir.
Yeah,
Yes.
so same thing. So I
Absolutely.
think we will leave it there. The
Ah.
point well taken. If you are doing it, it's an off-label use with clear understanding why you're doing. Put it in
Yes.
writing. Maybe take a written consent, as so
Yes.
the parents understand, and then you will have less trouble. All right,
Right.
let's move to the next special situation. Dr. Rishi, he has been silent. He's
Yeah.
our own colleague from Maharashtra. Welcome, Rishi.
Yeah.
You are in a
Thank
different
you,
role
sir.
today.
Yes. No.
You used to
Thank you,
conduct
sir.
these webinars. Now you are
Yeah,
part of the
yeah.
faculty. So quickly, cochlear implant is another special situation where there is confusion about vaccination. So why does this
Yes.
cochlear implant make it special situation, first of all?
Actually, cochlear implant itself comes under a high risk situation. And it has multiple issues like surgical issues are there, medical issues are there, and device related issues are also there. In surgical
Correct.
issues, due to cochlear implant, there may be facial nerve injury, CSF leak, wound infection, and bleeding, and there. And for
Correct.
us, basically, medically issue, it is high risk for pneumococcal meningitis.
Correct.
Because due to inner ear malformation and electrolyte infection and post-operative inflammation, pneumococcal meningitis due to cochlear implant is more important.
So anything in the middle ear can cross over to the top with the brain. And pneumococcus is a common cell in the middle ear. And that is the reason why you should be very worried about that. What else? Any other infection? Influenza?
Yeah, actually, influenza infection is the second most common due to cochlear implant.
All right. So which vaccine would you give and how? And when?
Regarding the vaccines, sir, most important is pneumococcal vaccines because cochlear implant plans increase the risk of pneumococcal meningitis.
Correct.
So this already discussed. We have right now PCV 13 and also for about 2 years PPSV 23 as per age schedule. We can give PCV 13 and PPSV 23
Correct.
because the streptococcus pneumonia is most common cause of cochlear implant related meningitis.
Correct.
Second, the HIB is another vaccine which we can give post cochlear implant meningitis.
Okay.
And third one also we can think of influenza recommended also because influenza itself may predispose to secondary infection.
Correct.
Like otitis media, which
Correct.
is responsible for meningitis.
Correct. And more than that, if there's an inner ear infection because of any of this, the whole implant will be waste and you will have to remove it. So that's another reason why you will not want any of this middle ear organism to lead to havoc in such a child.
Yeah.
So one question, like Dr. Sundil said, for splenectomized patient, he will also give meningococcal vaccine. So for cochlear implant, why don't you need meningococcal vaccine?
Sir, regarding the meningococcal vaccine in the cochlear implant, because cochlear implant do not increase the risk of meningococcal meningitis.
Exactly.
And risk elevation is specifically for the pneumococcal meningitis and not the Neisseria meningitis.
Correct. That's
So,
because the proximity of the colonization of the pneumococci in the middle ear vis-a-vis splenectomized child, which is immune compromised. That's why he needs meningococcal. So that's the difference between the two. While there is no harm in giving meningococcal vaccine to any child, but it is not specifically required just because of the cochlear implant. So that's the basic question.
It has been given in, I think, national schedule in some countries.
Correct. And when do you give this vaccine? I mean, how long before the ENT person will say, I want to take up the child as early as possible? What will be your answer?
Means regarding vaccines.
Your vaccine that you talk, after how many weeks of those vaccines can the child undergo cochlear implant? Like splenectomy, said 2 weeks before splenectomy at least. Same way for cochlear implant?
Yeah, I think same.
Same 2 weeks because it takes 2 weeks for the antibodies to
2 weeks for inactivated and 4 weeks for the live vaccines.
Yeah, but anyway, we are not giving any live vaccine per se for cochlear implant. So 2 weeks is a reasonable period. All right, Dr. Bala, I come back to you, and very important. Of course, fortunately, we don't see HIV infected pediatric patients now as much as we used to see. Like as an hematologist, I used to see them in lots in thalassemic patients, and because of the thalassemia children getting HIV infection, somehow we took over the HIV treatment in the initial parts. till the time now the HIV has taken a backseat because of the very strong parent to child transmission program, which have prevention of parent to child transmission program, PPTCT, which has virtually eliminated pediatric HIV. But once in a while, you will still see a pediatric HIV patient. So the baby is HIV exposed and you don't know whether he'll be infected. Give BCG or not give BCG at birth?
See, basically, the simple answer to your question is that if the baby is symptomatic, definitely I wouldn't give BCG.
Correct.
Absolutely. If the baby is asymptomatic, I will definitely consider giving BCG.
Mm-hmm.
Definitely consider giving BCG. That is the recommendation. They say in countries like India, where there is high burden of
Correct.
tuberculosis, the
Yes.
benefits are probably higher than the risks of giving BCG. Unlike
Correct.
BCG, which is very, very dangerous in
Skid.
children who have SCID. You know,
Correct.
in HIV, it's not all that dangerous, though BCGiosis and other things can occur in HIV. But those infants will be symptomatic very early, and the CD4 count, if you happen to do, if it is very low, definitely you wouldn't give even BCG. And OPV is another thing, it's better to avoid.
Yes. Correct. Correct.
Avoid,
Correct. So
avoid.
that's the second question, that OPV you should avoid, especially when you have IPV available, which
Yeah.
you can use in these children, because if an alternative is available to a live vaccine, you should use that alternative. I mean, that's the
Absolutely.
dictum in HIV infected patients.
Absolutely.
So whole idea of this BCG not give was started by the study that in Africa, where before the heart treatment, the antiretroviral treatment available, those babies who were given BCG at birth, even when they were not immunocompromised. Later, when they became immunocompromised, they developed BCG even after years. But now today, as I said, with the PPTCT program, when mother-child combination is given triple drug, and during delivery also they are given the drugs, and they are told about the risk of transmission by breast milk or top milk or breast milk, the incidence of HIV transmission come down to less than 1%. So for that 1%, you cannot relay in 99%. What you can do is, if there's HIV exposed baby, you can actually do a DNA PCR at day 14. If it is negative, do one more and say there's negative, and you are sure the child is exposed but not infected. If the child is infected, still, as Dr. Bala said, because the risk of TB is much more, probably you will still give, but after starting the antiretroviral therapy, so that there is no problem of BCGiosis happening in the child. All right. What
One
about
minute,
me?
one minute,
Yes.
Nitin, 1 minute.
Yes, yes.
Very
Yeah, yeah.
important, often forgotten piece of advice is it's not only important to tell the parent don't give OPV to this index case, but also to household.
Contacts.
I mean,
Yeah.
that's more
Household
important.
context.
Yes,
Yeah,
yes,
you
yes.
should tell them
Yes.
if there are babies in your family below 5 years when there is pulse polio or something like that, or if polio drops are being given to the children, please avoid giving to household contacts.
Correct. That's true for all immune compromised hosts, onco patients, transplant
Yes.
patients, and we'll come to that a little later.
Yeah.
Okay, what about measles containing vaccine, Dr. Bala?
Yeah, it's symptomatic, definitely again, you should not give.
Put them on heart.
Yeah, if they are asymptomatic and if the CD4 count is more than 200, you can definitely consider giving the live vaccine. And
Correct.
inactivated vaccines are absolutely safe. I
Okay,
mean,
so measles containing vaccine gets a priority because measles can be fatal in a child with HIV. Others like varicella, live hepatitis A, you will avoid because you have inactivated hepatitis. But varicella, because you don't have a killed vaccine, you can give it once the patient on antiretroviral therapy and the CD4 counts have come to the reasonable values for the age, or for a child above 5 years, they are more than 200 or more than 500. All right, inactivated vaccine, if you give to a symptomatic child who is not on antiretroviral therapy, you think it will be immunogenic, though maybe safe?
they are very safe. The immune response in a very young infant is likely to be good. Longer the duration of the disease, the less is likely to be the antibody response. And not only that, it has been shown that the antibody titers in HIV infected children with progression of the disease, the titers tend to come down, particularly titers to measles, titers to tetanus,
Correct.
even hepatitis B. Yeah, and there are some centers where they even give double dose of hepatitis
Booster.
B in
Yes,
HIV
that's
infected.
Yeah.
correct. So I think point well taken, that you should have a good immune system status before you start live vaccine. which you can easily attain by putting the children on antiretroviral therapy, and within 6 to 8 weeks time your immune suppression would be overcome, and that will be the time you can safely give the live vaccine. If you can do a CD4 count, then age appropriate CD4 count, which in a small child will be anything more than 15% of the total lymphocyte count, or any child who's above 5 years, more than 200 to 500 absolute count is a safe time. If you don't have access to doing CD4 count, like in a small place, you can look at the absolute lymphocyte count. And if they are above 2500, you presume that this child is not very severe immunosuppressed, and maybe such HIV child should be given all live vaccine. So, and when you give this vaccine, of course, look for the side effect. As Dr. Bala says, sometime in an immunocompromised host, you can develop a live vaccine induce some complication. All right.
Nitin,
Yes,
just
yes,
to add,
yes,
just to add, ARV should not be delayed or postponed in
oh,
any
yes.
child with HIV, whatever the status of the disease.
Correct. And it is must to give local antibody even for class 2.
Yeah,
And
yeah.
for every re-exposure, you have to give a local antibody, because your immune response cannot be relied upon. I think that's a very important point.
Yeah.
Rabies priority, irrespective of the condition of the child, including monoclonal antibody at every exposure in the baby.
Absolutely.
All right, perfect. We move to Dr. Sunil. Now
Yes,
we
sir.
come to a major chunk of immunocompromised host. So first of all, which immunocompromised conditions are more at risk for problematic of vaccine preventable disease, and also risk of developing side effect of live vaccine?
There are two kinds of immunocompromised host. One is primary immune deficiency, and
Correct.
another is acquired immunodeficiency. So
Correct.
in that condition, already we have discussed about HIV. Now the
Correct.
second chunk is chronic use of corticosteroids. Because
Correct.
we are using in left and right in our practice.
So let me I will ask you to clarify what dose of steroid and what duration is immunocompromising that you should avoid live vaccine.
Sir, this is the rule of 2. 2
Correct.
milligram per kg or more than 20 milligram per day for 2
Correct.
weeks. For 2
Correct.
weeks, then the HP axis is suppressed. Then
Correct.
only
And
live access has to be not to be given.
correct. And
Inactive-
when can you give live vaccine to such a person when he's off for
Sir,
how long?
after stoppage of this steroid,
Or
we
bringing them
can
down
wait
to
for
below
1 month.
20.
We can wait for 1 month. 1 month after stoppage of.
So you have to completely stop or bring it down to less than 2 mg per kg or less than 20 mg absolute.
Sir, till this high dose is
Suppose someone
given.
is 5 milligram on alternate day.
So that is not a contraindication.
No,
That
so
is,
at what dose it is not? No. Someone was on, say, nephrotic was on 60 mg,
right, sir.
and then now after 4 weeks has been tapered, and now it's come down to 5 or 10 milligram alternate day. Is not more, is more than a month. Now you have to really stop all steroid, or at that level of steroid.
Sir, where it is less than 20 milligram or
Correct.
alternate day steroid, there is no need of stopping. If
Correct.
1 month has passed from the high dose, then we
Correct.
can safely give the live vaccine.
So I think this is an important message, delegate, that high dose means 2 mg per kg per day, or more than 20 mg absolute amount for more than
Right.
2 weeks. The child is immunocompromised.
Exactly.
Now
sir.
you have to bring him back to a level below this for a month before you will start live vaccine. Am I
Yes,
correct?
sir. Yes,
All
sir.
right.
Yes.
All right. So which vaccine can be given to such children?
So these children are very prone for, again, pneumococcal infection. And
Correct.
another
Why are they prone, especially like nephrotics? Why are they prone to?
Sir, nephrotic syndrome, it is again a immune altered state. There is a
Correct.
T cell dysfunction, number one, and number two, many immunoglobulins they are being
Correct.
lost in the urine.
Correct, including
So-
some complements.
So
Yes.
both the T and B system are less active, and that is the
Correct.
reason they lead to
Correct.
pneumococcal sepsis and pneumococcal peritonitis many a times.
Correct. So you will definitely give them pneumococcal vaccine if they have not received in past,
Yes,
age
sir.
appropriate pneumococcal vaccine, and
Yes.
give vaccine, because these are the primary organisms which again are at risk for developing severe sepsis. Now,
Yes.
which are contraindicated? All live vaccine?
All live vaccines, oral live vaccines can be given.
What
Live
about
vaccine.
what about oral polio vaccine?
Oral polio vaccine, again, again, it is a debate, but still,
The pulse polio campaign doesn't discriminate for anyone, even for a
Yes.
primary immunodeficiency. But
Right,
because
right.
steroids lead to severe B cell and T cell lymphopenia,
Huh.
they have a lot of hypogammaglobulinemia. So they
Huh.
are very prone to develop a VAP-like syndrome
Yes.
if they are on steroids. So I would definitely avoid giving oral polio vaccine because there is an alternative available in the form of injectable
IPV.
polio.
IPV.
Right.
If
Right.
IPV is there,
All right.
IPV.
so go for
All
that.
right. Now the question, Dr. Sunil, is someone has taken IVIG replacement therapy. Of course, it's not immunocompromising, but now the child may not respond as well. So, which are the vaccines which you will delay, why, and how long?
Sir, number one, IVIG, intravenous immunoglobulin given, it depends on the dose of IVIG, number one.
Okay, I
And
will say
number two,
it was 400 mg per kg, one scenario, and 1 kg or 2 kg, 2 gram per kg in another scenario. Now you tell me in both, what will you do?
400 milligram per kg, we can wait up to 6 months, and
Okay.
and more 1 gram or 2 gram, we can go up to 10 month to 11 month. So
Correct.
what will happen? A Kawasaki-like condition when it is 2 gram per kg used,
11
then
month.
up to 11 month, we cannot go for live vaccine like varicella and like MMR. These
Measles
two has
containing
to be
vaccine.
given after
Correct.
that.
I give an example to my students that why don't you start MMR or measles vaccine before 9 months? In fact, some countries don't even give before 12 months. Why don't you start your varicella vaccine before 12 months, even in a normal child? That's because the transplazmal matrix antibodies will remain active till that age and will interfere with the uptake of the live vaccine. Same thing when you give a very high
Same
dose
thing.
IVIG is as good as
Yes.
giving a transplasmal matrix antibody, a bolus. So same principle. So I think that easy for them to
Yes,
remember
sir.
why
That is the principle.
10 months, 12 months like that. But
Exactly.
suppose someone has taken blood product like Paxil, FFP, or tetanus immunoglobulin, all these also you have to delay the live vaccine.
No, not necessarily, sir, but blood products and plasma, which contain good amount of antibody, it is a
Correct.
dictum that we should delay for at least 6 months.
Correct.
6
So
months. This MMR,
PRBC, the packed red blood cell, has very little plasma. So you can give up to 3 months, but other
yes,
plasma containing vaccine or specific immunoglobulin or standard immunoglobulin, you will wait for 6 to 9
6
months.
months. Yes,
All
sir.
right. Now the last question on specific condition like complement deficiency. What are
Sir,
they at risk of?
hypocomplementemia or complement deficiency situation, they are again prone for capsulated sepsis.
Polysaccharide,
So
correct. Same
polysaccharide,
as splenectomized patient.
same.
Right.
Just like your splenectomized patient. So pneumococcal will be number one, number two hip, number three will be meningococcal because all of them require complement for the phagocytosis.
You talked about primary immunodeficiency. So what about patients with say humoral like hypogammaglobulinemia? Can they receive live vaccine?
Actually, if it is a T cell one, then there is no
They should not.
question of
Correct.
giving live vaccine. But in those conditions, live vaccine can be given. But
Correct.
the bacterial vaccines and kill vaccines are of no use.
Correct. So patients who are combined immunodeficiency or pure T cell deficiency should not receive any live vaccine because they can lead to severe varicella like primary pneumonia, what do you call giant cell pneumonia, and so also measles can lead to a giant cell pneumonia. Okay, so I think we have discussed enough about the immune compromised host. Now let's move to yes,
Just one
Bala.
comment. Just one.
Yes, sir.
I think we should remember that there is one vaccine which is not contraindicated in any.
Yes, which one? Let the crowd answer. Anyone from the crowd can put in the chat box. Can you give an IVIG? Which vaccine which is live can still be given? Besides, of course, oral polio and BCG. Anyone in the chat box? No, okay, Balaji, continue.
No. Inactivated vaccine.
Okay, inactivated. Yes.
One vaccine which is not contraindicated in anybody is influenza inactivated vaccine.
Yeah.
Inactivated. Yes, sir.
Perfect.
Yes,
Given
sir.
to any immunodeficiency, whether it's HIV, anything.
Yes, sir.
Even in
So-
SCID, you can give influenza vaccine, though they may not respond well. That is one. Second is, in all these children who have immunodeficiency and situations like HIV, when in doubt, you should estimate antibodies.
Correct.
That's
Yes.
another important
Yes, sir.
message I
Correct.
want to
All
give.
right. So my catch question in the PG exam is that one vaccine that you can give even after 2 gram per kg of IVIG injectable live vaccine is yellow fever because no
Yes.
donor has yellow fever antibody upfront unless he's been immunized. And why would a normal donor be immunized against yellow fever? So that's one vaccine is not contraindicated to be given at any time after IVIG unless someone has a severe egg allergy. All right, Rishi, we have talked about
Yeah.
immunocompromised child and vaccination. But as Dr. Bala had said before, it's important also to look at the contacts because some of this vaccine can lead to confusion. So why
Yeah.
there's a special need of attention for the contacts of immune compromised homes? Like suppose there's a leukemic child at home, how the whole family has to be very careful when it comes to vaccination.
Actually, context plays a critical role in protecting the immunocompromised individual because the word immunocompromised itself that the immunity of that person is compromised, and that immunocompromised patient does not respond well to the vaccines, and they are more prone to develop infection. So
Correct.
infection in contacts can transmit easily. Even
Correct.
the mild infection of the contact may lead to life-threatening cases in the immunocompromised patient.
Correct.
And by vaccination, the contact, we can have the cocooning effect by giving indirect protection to the
Correct.
immunocompromised person.
Correct. So which vaccine should be given definitely to the contacts of, say, a leukemic child?
Yeah, the contact should be ideally fully age appropriately vaccinated plus special so certain specific vaccinations can be given. We can give
No, should be
influenza
given.
vaccines.
Should
Yeah,
be given, I'm talking.
should be given.
Which one?
Like influenza vaccines,
Correct.
inactivated influenza vaccine annually to prevent the household transmission. We can
Okay.
also give MMR if not contraindicated. We can give all varicella vaccines.
So when you
Then
give live vaccine to the contact, like the brother of the leukemic child who is still on chemotherapy, the brother is due for his MMR or varicella. When you give, is there a chance that he will transmit the vaccine virus to the leukemic child and that child can be problematic?
regarding the this
So you have a leukemic
uh,
child who is under chemo. His
yeah.
brother who is 1 year older is due for MMR and varicella. If you give it to
Yeah.
that brother, can that brother transmit the vaccine virus to the leukemic child and lead to problem?
Important means giving vaccine is to prevent exposure only.
That is right. That is to prevent
Yeah.
exposure to the wild virus.
Yeah.
I'm saying the vaccine
Yeah.
virus, can it be
Vaccine.
transmitted from the vaccinated child to the leukemic child who is in contact day to day?
No.
So unless the child has developed a rash,
Yeah.
you can develop
Rash.
varicella-induced rash. In
If
4 to
rash is
8%.
there, then we should.
Then you
postpone.
should separate out that baby for 2 weeks
Yeah.
from that leukemic child. But otherwise, live vaccines are not only safe, they are must. Because
Must.
ask an oncologist who is just induced a leukemic child in the first 2 weeks with heavy chemotherapy, and the brother develops varicella, and that gets transmitted to the leukemic child. I mean, that's a headache then to manage the children with IV acyclovir, chemotherapy being stopped in the first month itself, which is not good for the remission and so on and so forth. So contacts are very important. People don't pay enough attention to look after the contacts of an immunocompromised host. All right, Dr. Bala. Now, 2 important points. One is a chemotherapy child, which I will discuss with you, and then second will be the stem cell transplant. I will discuss with Dr. Sunil. So first, chemotherapy. When do you start immunization post chemotherapy?
Yeah, it's a very good, very practical question. Sometimes they will come from the hemato-oncologist to a general pediatrician after leukemia and complete therapy.
Correct.
The most important fundamental point that you must remember is that, unlike other immunodeficiency states or HIV, children who develop cancer, basically their immune system has been normal unless they have a pre-existing immunodeficiency leading to some
Which is
malignancy.
very rare.
Very rare, very rare. So by the time they develop malignancy, they would have received all the vaccines and the robust immune system of theirs would have taken care of their immune response very well until you start therapy. So we don't worry like in other immunodeficiency states. That's one. Second is regarding the starting 6 months.
Correct.
You complete the chemotherapy, you stop the chemotherapy. In general, you don't give any live vaccines during chemotherapy or for 6 months following the end of
Correct.
chemotherapy.
Correct.
End of chemotherapy. On the other
Correct.
hand, non-live vaccines are also best given after 6 months. They are not
Because
contraindicated.
yeah, but because they will not be respond if they are on chemotherapy, they won't
Yeah.
respond to even inactivated vaccine.
Yeah, the problem with the disease may not be very severe. The problem of immunosuppression due to the drugs
Correct.
will prevent the child from mounting adequate antibody response to even non-live vaccines. So it's better to avoid for about 6 months.
Correct.
Yeah.
After 6 months, there is enough immune reconstitution,
Yes.
and you can restart your. So now, when you give, do you give all that he has received in the past one extra dose, or just start from where he was left? Like, say, a 3-year-old child has received till 2 years. Now you start with 3 years onwards, or you also give one dose of every vaccine that he received in the past.
No, it's only a temporary immunosuppression. I don't think
Correct.
the T cells which are going to remember the antigen are going to disappear. So there is
Correct.
no need for extra dose.
Correct.
Okay, here again, the most important vaccine which should be given is influenza vaccine.
Correct.
That's, in fact, you should give even during chemotherapy.
Correct.
You don't
So-
have to pay. And if by any chance the child is going to receive transfusions, again, you should consider giving hepatitis B vaccine if with or without antibody testing. Because
Correct.
these children may require transfusions repeatedly. And so you have to worry about hepatitis B. And
Correct.
following treatment, re-immunization or catch-up schedule depends on the immunization status before the start of chemotherapy. By and large, most pediatricians and most oncologists would prefer to give one booster dose, age-appropriate booster dose at that particular time. Maybe, so for example, the child is 9 years old, you don't wait for 10 years, you give one Tdap 6 months after stopping chemotherapy.
Correct.
That's all.
Correct. So there are some things that you should keep in mind. Number one, the vaccines like meningococcal, polysaccharide, pneumococcal will be given to the children because they were immunocompromised, and you never know how much is the immune reconstruction even when you have stopped the chemotherapy. So they don't remain any more optional. Annual flu is must for these children because they can have still bad influenza, especially if they're like Hodgkin disease, where the immunosuppression can persist for 2, 3 years, 4 years, even after stopping chemotherapy. And last but not the least is that you should keep a good record. If possible, you can check for the antibody. It's not required, though it's not recommended, but if parents want, you can check the antibody, as Dr. Bala said, in an immunocompromised host. See that they have good antibody, then you need not worry about, and give those extra vaccine also to the children. Now, if suppose there is an exposure to an infective organism during chemotherapy, you can't give the vaccine. Then what do you, like say varicella, let's take varicella. Child of leukemia is exposed to varicella. What do you do?
You should definitely proactively prevent varicella. There is no doubt at all. And
Yeah, but you can't give him the vaccine when he's on chemotherapy. He has not taken in the past.
Yeah.
Now you'll give to the contact, but still he's developed varicella. Now what do you do? I mean, his brother developed varicella. Now what do you do?
You have to give, if available, varicella specific immunoglobulin. If not available, IVIG.
Correct.
If not available or not affordable,
Correct. And it will be IV acyclovir or oral acyclovir also will do.
See, valacyclovir, the bioavailability is better than acyclovir. Studies have shown you can give it orally, but IV is definitely superior to oral in terms of acyclovir.
Correct. And remember, the highest varicella load in the baby, in the leukemic child, when he's exposed to a contact, will be on day 6, day 7 of the primary contact, because that's the time when he's incubating. So if you are giving only acyclovir or valacyclovir, you start at 5 to 7 days after the exposure, not immediately. Whereas IVIG or varicella immunoglobulin should be given immediately, because that has a direct benefit of preventing any replication if at all. And if by chance the child develops varicella, if he's in a intense chemotherapy, admit him and give him IV acyclovir. If he's in maintenance therapy, then you can give him oral acyclovir. But that's one indication at any age to give oral acyclovir. Unlike in a normal child, like suppose a 5-year-old child is a varicella who is normal healthy, we don't give acyclovir, right? But immunocompromised children should be receiving oral or IV acyclovir.
Nitin,
Right,
yes. The least effective and the weakest option to prevent varicella is acyclovir. The foolproof method is varicella first immunoglobulin. The next is your normal immunoglobulin and IV immunoglobulin. Last only is the acyclovir.
Yeah, so when you give IVIG, don't give 1 gram and 2 gram per kg. You are not going to immunomodulate this child. It is a prophylaxis of 400 mg per kg is enough
Yes.
of the IVIG that is available. All right, Dr. Sunil,
Yes,
post stem cell transplant. This child is now undergone bone marrow transplant. Now we don't use the term bone marrow transplant, we say stem cell transplant. So when the vaccine can be started after the successful transplant?
Sir, here the policy is that after the hematopoietic stem cell transplant, what happens?
Correct.
All the memory cells, whatever
Correct.
is there in the marrow niche, that has been ablated. That means
Correct.
we can say marrow ablation has take out all the memory cells. So the child after transplant became a naive,
So
just
he's a
like
naive like a newborn child.
yeah, just like a newborn child
Correct.
who
All
has
right.
no memory cells, it will be completely unimmunized child. And
Yeah.
we have to start not any vaccine before 3 months. 3 to 6 months is the not before 3 months. 3 to 6 months, or some book writes 6 months to 12 months. We can
Correct.
start inactivated vaccine.
Correct.
And
And when to start
preferably
live vaccines?
yes, and live vaccine we have to start not before 24 months.
Correct. And that too, when the patient is most of the immunosuppression. Suppose the child has developed a graft versus host disease and
Yes,
he's on acyclovir, tacrolimus, something
right.
that should be brought to a minimum dose
Yes,
before you start live vaccine. So I think
exactly.
this is an important thing as far as stem cell transplant is concerned. And remember, when you select a donor for the stem cell transplant, see to it that the donor has received all the vaccine. Because
Yes,
in this child, the immune system is going to be of the donor. So
yeah,
while the
Yeah.
child is under immunosuppression pre and post transplant, so even the donor cells may not work as good, but it will be much better if the donor cells which are there are already immunized donor rather than non-immunized. So we would
exactly.
always prefer a donor to be given all the vaccine if he has not taken and then collect his stem cells so that we have T lymphocytes which are already sort of primed against many of these vaccine preventable
Exactly.
diseases. Right. So we have discussed which vaccine, how to give IPV when standalone is not available, and how to give HIP. That's also a question in the chat box. Suppose you have a splenectomized child and you want to give HIP. He has not taken any HIP in the past. Or a transplant child is naive, you said. So you want to give HIP. How will you give HIP, say, a 7-year-old child?
Sir, the question is that the real answer is that standalone HIB is not available. So when
Correct.
there is
Yeah.
an indication, just like splenectomy child, I want to give HIB, then I
Correct.
have to go for a combo vaccine. So
Correct.
that combo vaccine, one component is HIB.
Correct.
Sometimes giving little more antigen to a
Ah,
splenectomy child doesn't cause anything. And many a times we have read that the whatever diluent is there, that is to be used because they are combo and manufacturer has told that this
correct.
diluent has to be given. So
Correct.
instead of throwing out, it is always better little more antigen can be given. So we will be preparing enough some local reactogenicity
So
or
suppose you have a
fever.
14-year-old child who has undergone stem cell transplant, which vaccine will you give for IPV and HIP? You'll give a
Uh,
pentaxim, you'll give hexaxim, infrahexa.
yes, sir. Yes, sir. Yes,
At
sir.
14 years, it will be reactogenic or not reactogenic?
Sir, they are not that much of reactogenic, but still then we can manage with paracetamol.
So
Nothing,
this
nothing wrong.
post-transplant patient need 3 doses of IPV, 3 doses of HIP like any other naive child. So you give
Exactly.
0, 1, and then 6 months. So you give
Yes.
3 times infrahexa or a hexaxim type vaccine.
Yes, sir. Yes, sir.
Dr. Bala, what would
Yes,
you
sir.
do?
I'm not sure. I'm not sure whether I would. But to be very honest, I don't know the answer.
Correct.
Let's be very
Sir,
frank.
Sir,
just
one thing I want to ask.
Yes,
I
Dr.
don't
Nishi.
know.
Yeah, sir, regarding this injectable polio, the what government is having in that there while it is written to give subcutaneous or intramuscular only in
Correct.
government while they are not specify written for that fractional regarding the intradermal because
Correct.
in
So what
their
are you
vial it is
suggesting?
so from means that dose also can be given
So have you tried to
as
get, have you ever tried to get 1 dose of IPV for your patient from a
no,
government
not
setup?
one dose from the,
no,
but
no,
from that we can take.
no,
How will
no.
you get it, bud? They won't give you.
They will not
Even
give.
if there's a stem cell transplant 14-year-old boy in a public hospital where there is routine fractional IPV available, they won't give that full dose
No,
IPV for the
no,
child.
no,
So
sir.
it is not possible to do. IPV remains unimmunized if you have a problem with transplant. I mean, if it's a below 5 or below 7 years, you can, as Dr. Soni said, you can give the infant vaccine. But above 7 years, you take the chance and give infant vaccine, explaining well that there will be side effect. So that
Exactly.
is a problem. All right. So standalone HIP, the same thing. You can either use the combination vaccine up to 7 years very safely, After 7 years, you take a chance. I have seen some adult physician doing it, but otherwise for the hip, you can take the monocomponent out, dilute with 0.45 normal saline, but that was the diluent for the hip vaccine in the past, and give it instead of not giving at all. It is better to give that way by after taking a written consent. All
Exactly.
right, and
Yes.
and if the child has GVHD, as we discussed, then he's going to be on some immunosuppression. So you try to bring it down to as minimum level as possible before you give live vaccine post-transplant, but never give it
Yes.
before 24 months. All right, Dr.
Exactly.
Rishi, what about the solid organ transplant? Now, that's the problem. Solid organ transplant patient will be perpetually on immunosuppression for life. Unlike stem cell,
Yeah, yeah.
take off the immunosuppression and start all vaccination. What do you do
Yeah.
there?
Yeah, same here. Optimal time to begin the vaccination after transplant is not defined, but however, we can give most inactivated vaccines can be given starting 6 months post-transplant once
Correct,
the immune suppression is stable.
correct,
And like all inactivated vaccines can be given, and live vaccines are here are contraindicated
correct.
after the solid organ transplant.
Because there is
Uh,
no
uh,
level of immunosuppression which is safe as far as live vaccine is concerned. So it is almost not to be given. So can you do one thing?
yes.
Like suppose the transplant when a solid organ is never actually a what do you call emergency unless like a liver transplant in a hepatic coma child. So can you
Yeah.
then wait, give all vaccine as fast as possible to the baby and then do the transplant so that the baby is at least is before transplant and immunosuppression at least exposed to these antigens.
Yes.
Like
Before,
suppose you have a renal transplant patient, you know he's going to be
yeah,
gone renal transplant in the next 6 months. You immunize him as early as possible, so that you don't have to then
Yes.
worry about post-transplant
yes,
immunization. So that's
Exactly.
one way. The question only come in a metabolic liver disorder in a small baby, and I have a baby who was transplanted at as early as 3 months of life or 4 months of life, and there was not enough time. The child was so sick, so that child was given all the vaccine, whatever is possible, just 10 2 3 days 4 days before transplant. I don't know if it'll work or no, but somewhere I think I was in talk with some of the hepatologists and saying that why we don't do a combined study of hepatologists and immunization expert by giving this vaccine to these babies when they are immunosuppression and see what is the antibody response. Why are we presuming? I mean, there is not a single literature which actually pinpoints that at this level of tacrolimus, at this level of cyclosporin, or at this level of any other drug, there is a problem with even killed vaccines. So no one has done. I think it's a good time for us to do some such study so that we know and make a more meaningful recommendation than everyone doing haphazardly what one feels like in this situation. All right, the last 5 minutes before we take some questions which are there in the chat box, I did not include in my original question, but when Dr. Pakmode introduced the topic, he talked about pregnancy, and that's a special situation. So, Dr. Bala, why pregnancy is a special situation, and which are the vaccines that you would definitely give to a pregnant woman?
Influenza vaccine and Tdap are a must for pregnant mothers.
Uh-huh.
And live viral vaccines, I wouldn't be advising for pregnant ladies.
Correct. And rabies is always to be given irrespective of the month of
uh,
gestation because the life of
yes,
the mother is important. And RSV immunization is not available in our country, but RSV immunization for pregnant women is available. So maybe that can be considered if you are not going to give the monoclonal antibody, which is expensive. The vaccines are cheaper than monoclonal antibody. And why do you need this vaccine in pregnancy? Only for the baby or also for the mother?
One mother fights for the mother also. Mother also.
Correct.
In fact,
both.
no, we should not forget even adults can get pertussis.
Correct.
I've
And
seen adults with
and
pertussis.
influenza being very,
Influenza
yeah,
can be a killer in pregnancy. So,
correct, correct,
and
correct,
rabies, we know it's 100% fatal. There is no question,
correct. All
uh,
right.
excluding the protection for the mother. And this
Correct.
concept of cocoon vaccination has come to be accepted. In
Correct.
fact,
Yes,
I have had phone calls from many pediatricians,
Correct.
physicians calling me, sir, I'm going to New York. My daughter is telling me to take Tdap vaccine and come. Should I take?
Correct.
You should
Correct.
take. Is grandparenting safely for your grandchild? Because in the United States, pertussis in New York, the number of cases of pertussis is much more than 4 or 5 Indian states every year.
Correct.
That's because there is so much of good surveillance. And the
Correct.
pertussis that occurs in US is very severe that
Correct.
anybody who travels to US, any geriatric man, even middle class person who's going to see a young child, he should take Tdap
Correct.
vaccine.
Correct. So the pertussis in a mother is to prevent severe pertussis in the baby before the vaccine can take charge. And you need 3 doses of pertussis containing vaccine to protect the child, which will be earliest like 16, 14, so by 18 weeks. So for the first 18 weeks, the baby is exposed to pertussis, can develop severe pertussis. If he is taken, the mother has been given Tdap vaccine, then that window period is blocked to a large extent by the transplacental matter antibody, especially in a full-term baby. And that's the reason why a pertussis vaccine in the mother is very important. And in fact, it has been studied that the cord blood level and the level in the baby at the time of birth and the level in the mother, they correspond. So there is a concentration of the antibody in the baby as compared to the mother for anti-pertussis. And that is the reason why the same is true for influenza vaccine. That first 6 months, no vaccine can work for baby. So you cover that period by giving influenza vaccine to the mother. As influenza is very severe during pregnancy because it's an immunocompromising state, and also for the baby for the cover for the first 6 months till the vaccine can take. Now we have one question in the chat box. Of course, that's nothing to do with the special situation, but Dr. Chandrasekhar Patra wants to know that if a child who is 7-year-old has taken all the vaccines so far in the primary schedule, but at the age of 7 years now got rituximab, so what precaution you have to take?
It has to be repeated, rituximab. If rituximab is given, it completely wipes off all the immunity, unlike
cells.
other.
Correct.
Yeah.
Correct. All right. So I don't see any other.
It has to be repeated after 6 months. After
Correct.
6 months, yeah.
One question was there someone wants to give Hib vaccine to a child who's more than 5 years now. How do you give? We already said that you either repeat
Yeah,
the
it
infant
is.
vaccine or you take the monocomponent of Hib and dilute in 0.5 saline. All right. Dr. Sandeep Vasankar wants to know, rather than telling us standalone IPO Hib or DPT is not available, rather ACVIP should make it available via via vaccine companies. So that is a big task to tell vaccine companies what to do. They don't listen to anyone. They only listen to the government. So unless the government makes it compulsory for it to be available, I don't think so any one of us have so much clout to say that it should be made available. But a point well taken that maybe the drug agencies like the FDA or the DCGI can take this suo moto. Maybe IIP should write. In fact, I had written to the IIP to say that they should write to this authority to say that why these standalones are not available for use in children who are in special needs. All right, is all about money spent versus adequate protection. I didn't understand that question. Which money spent and what protection is it talking about? Then why patient should be spent for combo vaccine when already taken? So he's saying that is it because of the money involved in a combo vaccine that's why standalone are not available? Partly true. Partly true. I mean, I would say partly true. The standalone vaccines have been withdrawn by many manufacturers because their combination vaccines are there because they are worried about combination being not used if single monovalent vaccines are available. And all right, and in high risk cases in catch-up, missed out standalone vaccine. Correct. So I think point well taken, Dr. Sandeep, that we should have standalone vaccine available at least for this special situation. And I will make another effort on my part after your post in this dialogue. I will write to some of the vaccine manufacturers saying that why they don't make either IPV and Hib available to the patients who need it. All right. Is there any other question? Like Delhi government is giving intradermal fractional IPV. All over the country, Dr. Alok, they are giving intradermal IPV. But as I said, their intradermal IPV is not available for full dose IPV use in special situation like stem cell transplant. So that's the unfortunate part that though the vaccine is available in plenty, is not available for us to be used in a special situation. Penta or Hexa after 7 is very much reactogenic. So, what can be advised? So the question is very right, Dr. Naresh. They are, but it's not like you can't give it. In fact, how many of you know? Now I'll take a brand name again because I know that brand Tetraxin, which is IPV DTAP, is actually licensed till 12 years of age. So it's not that you can't use it above the age of 7 years as we have been taught. So in a special situation, yes, make it a point to use. It's better to have little pain than to get remain unprotected against IPV and Hib. All right. Any other question? Most of them are only putting their own names and their MMC number because they get 1 point. All right. I saw some more. Rabies vaccine.
One more question is there. Is
rabies
measles
in
giving Kakuning
immunocompromised.
vaccine?
Rabies in immunocompromised, we already discussed that all immune compromised rabies gets priority. They take full 5 doses, not 4 doses, and they also take monoclonal antibody for every bite, even when it's re-exposure or is class 2 bite. Okay, how does one cover?
Nitin,
Yes, sir.
There is one question on measles as a cocoon's
Yeah.
vaccination.
Cocoon.
Please. I
Some
can't see. Please go ahead. Read the question and answer both.
yeah. The question is measles given as a
Cocooning vaccine.
in recent outbreak in US? The reason why geriatric persons who go to US need not take MMR vaccine is that all of us would have been exposed in early childhood. All of us would have had antibody. There is no recommendation to take MMR vaccine for a geriatric person to go to United States because there is a threat of measles outbreak in US. I agree, but there is no. I don't think adults who go out from India need to take MMR vaccine.
So I think the basic question of cocooning is to prevent the person going from India and going and infecting the baby.
Correct.
Here is the reverse. We are immunized. The baby there is not immunized because of the stupid rules. That's why there are measles outbreak. In fact, the Europe is likely to miss out on their measles elimination certificate after 30 years because they have enough cases now. So it's a very, I mean, what do you call a paradoxical situation that we are now measles eliminated in many parts of the country, but they may actually lose their license. All right, there's one more question from Dr. Amay Kakirde that what about neonate who received IVIG? So we said IVIG, the only live vaccine which have to be delayed are the measles, MMR, MR, varicella, and live hepatitis A, which anyway are given beyond 9 months of age. So the gap you keep between high dose IVIG and the next injectable live vaccine is 9 to 12 months. So it will be given at the appropriate age. The question comes only in older child. For Kawasaki, like suppose a 1-year-old child has received 2 gram per kg of IVIG for Kawasaki, he can't receive his varicella and MMR for the next 10 to 12 months.
11 months.
All right. Then any other question? I think we have answered most of the question. Is there anyone who wants to ask question? We can open up the admin. Can you just unmute everyone? We have another 10 minutes. Anyone can ask question or give a remark if they want to.
Pallavi madam, unmute करा सर्वांना.
सगळ्यांना unmute करा please.
Yes, sir. Done.
सगळ्यांना unmute करा. Anyone wants to ask question? Please go ahead and ask. Or anyone wants to pass a comment, please.
Yes, done, sir.
Yeah. Okay.
Taide. Dr. Naresh Taide want to
Dr. Naresh is
Dr. Taide, please.
Sir. I think in sickle cell, we should also, HIV should be a important vaccine.
Yes.
Because most of the sickle cell disease may have hepatic crisis and they may die due to that.
Oh, perfect. Hepatitis B and hepatitis A. Yes, sir. Very well. Point well taken. Yes, sir.
Because hepatitis B already given in the government program, but hepatitis A is not given in the government program.
In fact, I was in a meeting with the NII, the National Institute of Immunohematology. They did a 3 days workshop for sickle cell disease in Maharashtra. They had invited me to speak on vaccination. I couldn't go, but they were trying to push the government to give these extra vaccines to every sickle cell baby, which are not part of the NIP. I don't know what happened after that, but maybe yes, that's a point well taken. All right, Dr. Sandeep also is asking question. Dr. Sandeep, you can ask question directly. Unmute yourself.
Yeah.
Ji. Hello, sir.
Yes. Do you have endemicity research trials studies with regards to JE?
You mean in general, you are saying, not in special situation. So in general, the JE endemicity is decided by the government of India, and more districts are getting included as being JE endemic. So just to give you an example, now Navi Mumbai is JE endemic, Thane is JE endemic, Raigad is JE endemic, but Mumbai is not JE endemic. So from 2006, when I was the president, where some 8 districts were JE endemic. Today, we have more than 350 districts which are JE endemic. And 28 to 29 of these districts, the JE has also started showing in adults as a shift to the right after the baby vaccination has controlled the JE in the children. So they are now giving even an adult JE vaccine upfront. So this is especially in Assam and in northeastern states. So more and more districts are getting affected with JE. So how will you know whether your area is JE endemic or no? If JE vaccine is part of your local program, like say in Mumbai, municipality of Mumbai, or in Navi Mumbai, then Navi Mumbai municipal program, if it's part of the public health in your area, that means your area is JE endemic. But you should not wait for that. And I would say you should offer JE vaccine to all children if you are in an area which is very near to the endemic district. Like suppose in Mumbai, now what the difference between Mumbai and Navi Mumbai? A lot of people do up and down. So it's a matter of time before when Mumbai also will become JE endemic. So we have started offering JE vaccine in Mumbai to all children, even when it's not part of the program here, but because it's a part of program in Navi Mumbai and Thane. So I think that's the approach you should take as far as, and it's a very cheap vaccine, two
Very cheap
doses,
vaccine.
and it is very effective, and it's a dreaded disease. I would say that even more than meningococcal vaccine, JE is something which you should offer more often to our patients.
There
Yeah,
one
you
more
absolutely.
query. One more query.
Yes, sir.
Nitin, I have.
Other
sir.
is
Yeah, actually, now in Tamil Nadu, the government has introduced JE vaccine in the schools.
Correct.
And many parents have come and asked me whether my child should take. I always ask them to take. And
Yes.
one more reason why we should be advocating JE vaccine routinely. Nowadays, I don't, in my practice, at least 75% of the patients during September and December will say, I am going to Ooty, Aircard, or
Yeah,
some
yes,
hills,
yes, yes.
Kashmir,
Hill
and they
station.
travel so much. They
Correct.
travel much more than Nitin actually. So
So
they are all at
Yeah.
they are all at high risk of getting encephalitis.
So,
And
so for
instead of,
travelers from non-endemic to endemic area,
yeah,
the
yeah.
recommendation are that if you're going to be there for more than 2 weeks,
At least 1 month.
especially with excursion in open field and in interiors of like jungle life area, you should take JE vaccine before you leave your home state.
Yeah, that's one. The last thing is now the ICMR is about to complete a trial of alternating the two vaccines that are available for JE, the Bharat Biotech and the biological E.
Mm-hmm.
They are alternating. First dose they give double blinded. First
Mhm.
dose they give the biologically, and the second dose they give and two arms. And the early, in fact, I'm part of the advisory group for that vaccine study. The
Mhm.
studies have shown that alternating the vaccine does not affect the immunity. The preliminary
Absolutely.
reports are there. So they are doing it mainly because I believe that if JE vaccination is going to be introduced in the country, we don't have enough supply from one brand.
No, so now we have
Everywhere.
enough supply from both the brands. In fact, they are almost 50-50%, and they can jack up the requirement. Absolutely, there has been never like we have switched from the live vaccine SA1414 to Chengdu
Yeah.
vaccine to
Exactly.
our own individual vaccine since last more than 4 years. So I think we don't have to worry about JE.
From two
Probably,
doses,
yeah,
There
we
two
one
have
more
come to one
question.
dose.
Can
There
I
one
They
can
more
are
I
now
say
question.
something?
recommending one dose also now.
There
So
one
Can I
more.
one
say
dose.
something?
So
One
two
dose.
doses are actually what is studied, though one dose of
Yes.
the Bharat Biotech vaccine has been
Yes,
studied, but we
Genvax
have seen
is.
it after 2 to 3 years, the antibodies really drop very
Yeah,
low level. That's
okay.
why you should give
There,
the second dose.
there is
Dr.
Better
one
to
more
Sachin,
take
can
two
I
question.
say
doses.
something? Can I
So
say
There
something?
one by one,
one.
I see some hands up.
Yes,
First, Dr. Alok Bhandari, quick comment.
There is one more question.
Sir,
Yeah, go ahead, Dr. Alok, please go ahead.
sir, good evening, friends. My just comment is that medico-legally in this era, we cannot afford to take any chances under the goodwill gesture for a patient. Patient is a patient. Every patient is a potential litigant. If anything goes wrong, the blame on the doctor will come. Sir, मैं तो अनपढ़ था. I did not know anything, but you were a doctor. Why did you recommend something? Or why did you give some vaccine to my child which is not recommended medically by in the PI of the company also
I
and
think
literature also?
we will leave it to that, Dr. Alok. There are also differing opinions from other experts. So I would give an off-label vaccine if it's in the real interest of the patient.
Exactly.
So I have taken a written consent. I will face the music if it comes to.
There is one
Okay,
more
Dr.
question.
Many courts have given clear-cut decision, sir, against the doctors. Only for this
Okay,
stage.
sir. So leave it to the pediatrician what he wants to do. I understand
There,
what you
there
are
is one more
appealing.
question.
One minute,
One more
sir. One
One
more
minute.
hand, Dr. Nani Wadekar, and then you, sir. First, Dr. Nani Wadekar. Dr. Nani Wadekar. Okay, sir. Who are asking question? I see the name is Demouser's iPhone. Please go ahead.
There is one more
Nani,
question.
Nani, welcome.
Nitish,
Unmute kara, unmute kara, Sahib, unmute kara.
There is one more question. Can I ask?
Yeah, please go ahead. Yeah, go ahead.
There is one child of 14 months to be given chicken pox.
Yes.
Now mother is just detected with a diagnosis of pregnancy first month.
Correct.
Can you give chicken pox to the child?
So you give
Vaccine?
chickenpox vaccine to the child and keep him away for 2 weeks, especially if he develops an open rash. That's the answer. Dr. Nani, unmute kara, unmute. Dr. Nani Wadekar, unmute kara.
नहीं यहाँ PSRO है क्या लफड़ा पड़ा
No,
है
he's
Narendra
muted.
sir.
He's
यहाँ
unable to
PSRO
unmute.
है क्या लफड़ा पड़ा है
हाँ,
मदर से
अरे नाही
13
हा,
14 minutes
hello.
freedom છે
तानीवाडेकर
मदर
साहेब
से
महाराष्ट्रात
छोटू
असताना
Yes,
बोलायला
unmuted,
पाहिजे आणि
unmuted, sir.
जोराने बोलायचं.
આપણે
Ah,
પ્રેગ્નન્ટ
yes.
પાછી
See,
First
this
one
is not a
detect
special
કરવાનું
situation, but
હવે
there are
vaccine
patients who
chicken
come
pox
from
અપાય કે
US
નહીં અપાય
for a
Sir,
varied
एक
period
minute.
of time.
Can
She may
someone,
carry chicken pox virus
sir, can you mute your?
મેં ના પાડી નહીં
Okay, go ahead, Dr. Nani. Yeah.
Yeah. See, there are few patients who come from US for a varied period of time, and
Yes.
they come with their schedule, which is different than our schedule.
Correct.
What I feel is in India, the risk of disease is more as compared to the risk of disease in US. So,
Correct.
what advice we give is that when you are in India, follow the Indian schedule. When you are in
Correct.
US, follow the US schedule. So,
Absolutely.
we need to do some modification in this.
No, so you need to give BCG if the child has come from a non-endemic to endemic area like ours, if he's going to
Yeah.
stay for more than 3 months in our country.
Hmm.
And
Yeah,
as
that's
far as
true.
other like typhoid, hepatitis A, if they are going to spend more than 2 weeks in our country, then those
Hmm.
vaccines should be taken. or
Yeah,
given.
that we are doing. It's regarding this triple because they feel that they have taken one Tdap with Prevenar 30 or 20 over there, and then they have come here, and their doctor has told to take it after 4 months. But the child
Correct.
has landed in India where the risk is more. So naturally,
Correct.
what my feeling is that when the child is completed 28 days, the child should be taking his second dose.
Correct.
So
Agreed.
that should be the right advice, right?
Agreed. Yes, you write on
Yes.
paper, then they may or may not take is their headache.
Yes.
All right.
Fine.
Anyone else? Last 5 minutes. Dr. Sonavne, तुम्ही काय सांगा? Vaccine expert.
Sir, just for a discussion, suppose the child is having egg allergy, influenza,
Egg allergy. Egg allergy.
Egg allergy.
Egg allergy, yes, sir.
So severe egg allergy which has led to anaphylaxis in the past is a strict contraindication to any
Yes,
further
sir.
influenza vaccine. But any egg allergy just is not itself a contraindication. You will give it under supervision.
Yes. And chronic renal failure, dialysis patient.
They are immune compromised, like any steroid patient or like any other. They have to be given all the vaccines which we have discussed for the immune compromised condition.
And sometimes double dose hepatitis
Yeah.
B.
So like
Yeah.
there was a study done from Tata Hospital when hepatitis B vaccine was not part of the national program. A lot of the leukemic would survive leukemia would die of chronic hepatitis B. So they tried to give hepatitis B vaccine to these children while they were on chemotherapy. So they used to give double the dose and double the number of doses, which means 40 microgram, 6 doses. And yet the seroconversion at the end was around 20 to 30%. So those drugs which we use in leukemic children are so immunocompromising that the time is not there to give the vaccine then. They should have taken it before. Or so what we started doing is give them immunoglobulin every 3 months till the time their intense phase is over, because it's the intense phase during which time they are going to be exposed to blood product. So we would cover them. So that's what we used to do 15-20 years back. But now fortunately hepatitis B is part of national program. Every baby born has taken it, so we have not to worry about hepatitis B anymore in our onco patient. Dr. Jagruti, welcome. Please.
Hello, sir. Sir, I have one query that nowadays PCV20 is given in the Western countries as a part of their immunization schedule.
Correct.
If there is a patient who comes from there with a first dose of PCV20
Correct.
taken there, can we give the current PCV20 which is not yet licensed for use for
Correct.
children?
So I would give it with written consent, but Dr. Alok will not give. He will say, I will only give Prevnar 30. That is the difference of opinion between two of us.
I will give. I will give.
Bala also will give.
I have given already.
Sir, I will give it.
Okay.
Practically
All
give
right.
it.
I think we have.
question.
Yes, one more last.
Sir,
Yes,
can I
yes,
ask
please.
one more? Sir, so I have a patient who took MMR vaccine on 1st November and today came with parotitis. So how to
So
differentiate
today means
whether
3
it is
weeks past.
4 weeks?
So 3 weeks is the time when the parotitis, vaccine-induced parotitis peaks in mumps vaccinated children. So it's known complication, no worries.
So this can be considered as a complication of the vaccine?
Yes, anything which happens in 6 weeks, within 6 weeks of MMR vaccine, any parotitis is, unless proven otherwise, vaccine-induced parotitis. And it would generally disappear within 3 to 4 days time.
And sir, do we need to
One
report
correction.
it? Or...
Yes, Balaji.
One correction. It is not a complication. It is an adverse reaction.
Yeah, absolutely.
Yeah.
So do we need to report that?
You should report any adverse effect you think is because of vaccination. Even mild fever after any vaccine, you can actually report. That's what they do in the Western countries.
AFI.
All right, I think we have crossed our time.
One question from
yes.
Dr. Manish Shah. 3-valent versus 4-valent influenza comment.
So now all influenza vaccine in the next 1 or 2 years become trivalent because Yamagata strain is not circulating for last 3 to 4 years. So you can remove one antigen, the cost will come down, your capacity to make influenza vaccine will go up because ultimately all influenza vaccine are made on eggs. So less number of eggs you will require if you have only 3 versus 4. So this year being transition, some vaccine brands have 3 and some have 4, but I'm sure next year onward it will be all 3-valent. Till the time Yamagata comes back, it may become quadrivalent again.
Exactly. Thank you.
All right, I hand over back to the organizers. And first of all, I would like to thank the panelists for wonderful time and very crystal clear answers. I would like to thank all the people who have joined in taking active participation in this open question answer. And like to thank MyIP to give all 4 of us this wonderful opportunity to present our thoughts on this special situation. Over to Dr. Patil.
Thank you, sir. Really wonderful session. So on behalf of MyIP, I, Dr. Sachin Patil, extend heartfelt gratitude to respected Dr. Nitin Shah sir, Dr. Bal Subramaniam sir, Dr. Sunil Kumar sir, and Dr. Rishi Loda sir for crafting a wonderful academic session on vaccination in special situation under the flagship program of MyIP, that is the Vaccine Samvad. So we also thank all the delegates and for very interactive sessions and their attendees. And I thanks all the presidents and office bearers and team MyIP for giving this opportunity. Thank you, sir, one and all. Good night, everyone.
And I have a suggestion to Dr. Pakmode and the
Yes,
team
sir.
MyIP that
Yes, sir.
next session being the last session of the year,
Yes,
we may
sir.
do something different. Maybe
Yes,
it's
sir.
possible we can run online vaccine quiz for 1 hour
Okay,
and
sir.
give some very good prizes so that people
Yeah,
actually
yeah.
attend and participate. We will have a team of experts who will make some questions, and if possible, let's see whether on the Mentimeter or one of such apps online whether we can play that quiz game. So instead of discussing another vaccine, let's have a quiz time. But what we have learned in last 1 year, let's recapitulate in the form of quiz.
Exactly.
Yes, sir. Excellent means advice from your side, and it will be executed, sir.
Sure.
I think it sounds good, sir.
Yes,
so
good.
what I suggest is, sir, try to get all the faculties of the last 1 year, sir.
I will do that. I will take 10 of them. I'll take 10 of them, make questions, and we will make the little difficult, little easier one, and then run
mix
a
and
quiz.
match.
And let's give a good prize, good book or good something worth 10,000-15,000, so that people enjoy and they really feel the worth of
no
it.
issues, sir. No issues.
Right.
No issues.
Bring
We'll
all
take
the,
care
sir, bring all the all the experts of the last 1 year and try first number 1, 2, 3, sir.
Yes,
we'll
sure,
take
we
help
will
from
do.
Amruta's help will be taken and it will be executed.
Yes.
Alok sir, good evening.
All right. Okay.